So let's get started for today. This is our AI4C, Artificial Intelligence for Clinicians, that we have every Thursday at noon, the second Thursday of the month at noon. And today we have Dr. Omar Arnaout from Neurosurgery at Brigham and Women's Hospital. He's going to talk about AI in neurosurgery. Remember, again, we have this every second Thursday of the month. From September to June, and then we take July and August off and start up again in September. And we've had a number of great speakers, and we'll start after the new year, have a couple of great speakers and on through to May and June. But we'll have George Shee from Weill Cornell in January and Elliot Siegel from University of Maryland in February. Remember, you can view the past recordings at datascience.massgeneralbrigham.org. You can go there and view our past recordings. Please do fill out the survey. We'll have the link in the chat box for that. And you can go to our data science website, which is datascience.massgeneralbrigham.org, and see the educational activities there, as well as our lineup of AI4C lecture series. Next, I'd like to introduce our speaker, and we're delighted to have Dr. Omar Arnaout. He received his MD from Northwestern University Medical School, followed by internship and residencies at Northwestern Memorial Hospital, so the Windy City. He did fellowships at Brigham and Women's Hospital and Prince of Wales Hospital, and he is currently an assistant professor of neurosurgery at Brigham and Women's Hospital, Harvard Medical School. He's the director of inpatient services and PA education, co-director of computational neuroscience outcome centers, CNOC, and associate director of the neurosciences ICU. Dr. Arnaout has a particular interest and subspecialized training in treating patients with brain tumors, including those with gliomas, metastatic disease, and skull-based tumors, including meningiomas, acoustic neuromas, glomus jugulare tumors, and pituitary disease. In addition to traditional surgical approaches, he specializes in minimally invasive surgery, including endoscopic brain surgery. To him, the field of neurosurgery is not about the procedures, but rather the long-term relationships that he establishes with his patients. Good outcomes are tied closely to having strong therapeutic relationships, and as a result, he often sees his patients multiple times prior to discussing surgery, and then regularly in the post-operative period. For the patients he sees that do not need surgery, he is still crucial for him to have a close relationship so that he can help guide them through the outcomes that they are looking for. Dr. Arnaout has said that his most satisfying parts of his work can be broken down into three things. First and foremost, the patient interaction, which he really loves, and the relationship. That's the driving force for everything that he does. Second, the technical aspects of surgery, which can be demanding and unforgiving, but also very rewarding, especially when a challenging operation results in an excellent patient outcome. And third, his research in applying artificial intelligence to neurosurgical patients that will hopefully help better anticipate problems and understand patient outcomes and improve their quality of care. Today, in his talk entitled AI in Neurosurgery, Dr. Arnaout will discuss applications of AI and machine learning in the daily practice of neurosurgery and explore future avenues. So, Dr. Arnaout, I'm going to go ahead and stop sharing, and you can go ahead and share your screen.
Thank you, Kathy, and thank you so much for the invitation. Hopefully, folks will find this interesting. So, like you said, my day job really is taking out brain tumors, and the patients that we take care of are particularly vulnerable, and they're usually going through a pretty difficult time. So the common theme that you'll see throughout this is that that's the driving force behind the research, is how can we take better care of these patients. So I know there's a mixed audience, so I'm not gonna belabor the point about what machine learning is, but just really briefly, the idea, the genesis of the idea of machine learning is reversing the paradigm of computer programming, and instead of explicitly giving the computer a set of instructions and rules, giving it largely labeled data, and asking it to come up with the rules itself. This is the 30,000-foot description of machine learning, but and we do a lot of deep learning. But when I give this talk to trainees, which we'll talk about at the end, we really try to emphasize that as exciting as deep learning is for somebody who's just starting doing this, it's all the hype. It's really important to be comfortable with different aspects of machine learning more broadly, so that you're not tied down to one way of thinking about things. And we're very much advocates for the creation of this data science, data neuroscience person, which again I'll talk about at the end, which is somebody, in my view, who can bridge the gap between all these different specialties. There's many different kinds of machine learning, of course. Most of what we'll talk about today are ways of applying, supervised learning, but it's a much broader field. Okay, so that being out of the way, I'll talk a little bit about what we actually do. So, for those of you who don't know, the most common tumor that we see in the clinic is a glioma. A glioma is a primary tumor of the brain, and they, by and large, tend to be very aggressive in adults. They're almost always cancerous. They're always terminal, and people usually don't survive very long after the diagnosis, usually on the order of a couple of years. So it's a really tough disease to treat, and this is what it looks like on an MRI. It has a fairly distinct appearance. Anybody who takes care of this disease can look at the scan and tell you with a high degree of certainty that this is likely to be a glioblastoma, a high-grade glioma. And these are standard kind of Kaplan-Meier survival curves, and for the non-clinicians, these show you over a period of time what percentage of people are surviving, and you can see the step-offs as people die from their disease. And on the top left, there's two curves that have to deal with the highest grade gliomas, glioblastoma, and the two curves are for a particular mutation, IDH. And if you have that IDH mutation, which about 10% of patients do, the red curve shows that you actually survive significantly longer than if you don't. So that one mutation actually has a big implication on overall survival. And on the bottom right are the same two curves, just for the next grade down, the slightly less aggressive version. And it shows that there, the difference is even more dramatic. People who have that mutation survive a bit longer than the people that do. So it becomes important then to know if somebody has that mutation or not. And the way to know if somebody has it in 2022 is to take the tumor out and give it to the pathologist. And then they study it, and they use either immunohistochemistry or genetic testing or both to tell you definitively if the patient has that mutation or not. But I would argue that it would be incredibly nice to know ahead of time, before surgery, if somebody has that mutation. It would alter, to some degree, the conversation we have with the patient. And I would argue it would alter the way that I do surgery. For example, if I knew for a fact that somebody does not have the mutation, and therefore their survival is very, very limited, no matter what we do or don't do, I would be less aggressive. The last thing you want to do for that person is hurt them. If they wake up from the surgery with new weakness, you've then taken their short survival and shortened it even more. On the other hand, if you have a younger person is very likely to have that mutation, and they're going to survive a decently long period of time, well, then you can be more aggressive. And if they wake up with a little bit of weakness, maybe that's an okay compromise, because in return, they're going to live long enough to recover, to improve, and to see the benefit of a gross total resection. So the idea then became, well, is it possible for us to know ahead of time? Can we look at the MRI and tell who's more or less likely to have this mutation. And this was one of the oldest projects that I worked on when I started, actually as a fellow, and then stayed on as faculty with a wonderful group at Martinos. And the idea was to take Brigham MRIs, combine them with MRIs from a different institution and publicly available TCIA data sets, and see if there are radiographic features that can help determine this. So we built a convolutional neural network that had a binary classifier, whether the tumor was wild type or positive for the IDH mutation, using different sequences for each patient. And these are the AUC, the area under the curve results. And you can see that the AUC for the validation set, for example, is 95%, which is very favorable. So this work was published, and you can see that obviously a lot of people work on this. Jayashri was a fantastic partner to work with on this, and Ken Chang, who was her pre-doc in the lab at the time, and then several folks from our group. And publishing this is obviously a great step, but it's not the end result, because if this only exists on a publication, it hasn't actually affected the care of the patient, which again is the genesis of this whole thing in the first place. And I'll circle back to how we're trying to take this then and implement it in a clinical setting. But I'll pause this project for now and talk about a couple more. We talked a little bit about how the prognosis is poor for GBM glioblastoma patients broadly, but glioblastoma, the M refers to the multiforme. GBM is a very heterogeneous disease, and some patients actually survive a lot longer than you would predict. Some people don't make it very long at all. On the whole, it's a poor prognosis, but it would be great if you can kind of tease out who is going to do better than who, and use that to individualize their care. So this is another project that we worked on that used, this is the overall kind of sort of Kaplan-Meier survival curve. And these are some examples of variables. This is publicly available data from the SEER database, I think. And you can see how different variables, for example, in this case, whether they had surgery plus radiation or surgery plus adjuvant chemotherapy, changed their prognosis, their survival. And the question was, could we combine these different variables and create some kind of calculator that more personalizes an individual person's survival? So we took this SEER data, and which is this big national longitudinal data set, as I'm sure many of you know, and used it to tease out what we thought would be prognostic features, and used it to build this survival calculator. And the idea was, could we predict the chances of an individual patient being alive at the 1-year mark, and then create subject level survival curves for 10 years, 10 years being an aspirational amount of time. And these are the features that we had ultimately included into the model. And we tried, many different models, like one usually does when building one of these. They each have their, pros and cons. And ultimately, we built, published, and then posted online this calculator that you can go in and you can sit down and you can put in different individual patient characteristics. And instead of looking at a generic Kaplan-Meier survival curve for all comers, you can look at a Kaplan-Meier survival curve that more closely resembles the human being sitting in front of you. And we think this is a tool among many to have a conversation with patients about the outlook. So this is, like I said, this is published and accessible. But the good news is not everything that we see in the clinic is terminal, because that would be very depressing. Meningiomas are the next most common brain tumor that I see in clinic. Meningiomas are the opposite in many ways. They are almost always benign and very often curable with a good surgery. They can be technically challenging, but with a complete resection and favorable pathology, meningiomas can be curable. So they're basically on the opposite end of the spectrum from glioblastomas. And with meningiomas, the decision making in terms of who needs an operation and who doesn't can be quite nuanced. Unlike GBM, where just about everybody needs surgery, with rare exceptions, meningiomas are different. A lot of people don't need surgery, and you can watch them. One of the things we look at when we decide, does somebody like this need surgery? You know, this is a challenging skull-based meningioma, and I don't know if my pointer shows up, but this little curvilinear black mark is the carotid artery, and this is encased totally by the meningioma. So, you know, when you're sitting talking to this person and their family, you want to be very thoughtful about, does the risk of surgery outweigh the benefit or vice versa? And one of the things that we look at when we're making that decision and having the conversation is, has this thing grown over time? Is this a static, indolent lesion, or is this something that's growing and therefore in your lifetime is going to be problematic and really should be resected? And even if you've never seen a brain MRI, you can probably tell this is a non-uniform shape. I mean, this is not a sphere or a cube. It's a fairly complicated three-dimensional shape. And to the surprise of many, the way that we clinically measure dimensions for something that's this complex in 3 dimensions is linear 2-dimensional measurements. So a human being, an expert radiologist, will sit down at a computer, find a 2D slice that they think represents the tumor well, and make linear measurements, which really is kind of a crazy thing to do in this day and age, because then you're comparing apples and oranges each time you look at a scan. The slices are different, there's human error, and so on. So for meningiomas, one of the questions that we had was, could we come up with a volumetric, a 3-dimensional way of measuring growth over time? And for a long time, there has been a way to do it, but it just involved manual segmentation. Again, a human being sitting there and manually drawing out the tumor. And we wanted to see if this can be done in an automated way that is much less labor intensive. So this is what a 2-dimensional measurement looks like. And again, you can easily see, I think, how just moving those lines a little bit will give you wildly different numbers. And it's actually a hard thing to make decisions based off of. So if you did it manually, the volumetric analysis takes a lot of time. It requires somebody who knows how to do it. It almost always requires third-party software as opposed to the clinical PACS. And it can be a subjective, not straightforward thing to do. So along with Satra Ghosh from McGovern, we wanted to explore creating an automated way to segment these. So we sat down, we had a segmentathon, which is one of my favorite words that we came up with. But we sat down as a big group of different people and segmented almost 1,000 meningiomas from our own institutional data set. And we used this to build a 3D CNN that had been pre-learned on non-medical image set. And then we looked at a couple of things. We looked at how good of a job it did with labeling, of course. And we also looked at, just for fun, how long it took the program to do it versus how long it took a human being to do it, which obviously was going to be a big difference. And I'll show you some examples because I think it's cool looking, but this table reflects that we had captured all the different types of meningiomas, which can be, some of them are rare and quite complex, but our training data set was pretty comprehensive. And hopefully this works. The video. Oh, I think it was about to work. Well, bummer. Well, if it did work, so I guess we'll look at one picture, but on the, oh, there it is. It is working. How good is this? You can see there. Okay, so on the top left, you can see brain scans, brain MRIs. On the bottom left, you can see the human expert generated labels. On the bottom right, you can see the labels generated by the CNN. And on the top right, you can see the delta between the two. And our performance metric for this model was a dice coefficient. And on the bottom right, you can see the dice coefficient. And I won't make you watch the whole thing. But these are sorted from highest dice to lowest dice. So as you go on, the dice goes down. There's only a couple that have a very low dice, and you can see those fall off at the end. But really, for the vast majority, the dice was great. So the concordance between the human expert and the machine was quite good, quite good. It was in the mid 90s for the vast majority of the data set. So this was really promising. This was a nice result. And we're hoping to be able to use this, like I said, to think about indications for surgery in terms of growth, but also when people get treated, because oftentimes people get treated with non-surgery, with radiation, and then you're looking for maybe reduction in volume, and you can use this model for the same thing. We also think that being able to automatically segment these brain tumors and pull them out of the picture is a good way of pre-processing these things for other interesting machine learning projects. So, for example, if you wanted to look at, can we predict different grades, or can we predict behavior over time, then the first step would be to, take out the noise being, the rest of the brain. And by creating an automatic way to segment these tumors, we've solved this first pre-processing step for other projects. And then as a fun side project, we explored whether we can use generative adversarial network scans to create new brain tumors in fake people. And I just think this is interesting and cool, but these are all computer generated non-humans that have meningiomas that look actually very realistic. And this would be a way of, for example, supplementing your training data set. As usual, lots of very talented people, worked on this, and Satra and Jakob, who was his pre-doc at the time, were instrumental in helping get this together. And then I was going to switch topics a little bit, even though I'm a brain tumor surgeon and my passion is in brain tumors. A lot of neurosurgery is actually spine surgery, and it might be hard to believe, but there is intelligence and artificial intelligence in spine surgery too. So we've done a couple projects with our spine partners, and this one I think is interesting to talk about. So spine surgery often involves the implantation of hardware in people's spines. One of the most common spine surgeries is a cervical decompression. It's a bread and butter surgery that's done, hundreds and hundreds of times every year at most places, including ours. And this is a plate. If you get one of those surgeries, you'll almost definitely end up with a plate. This is a plate in somebody who's had one. The thing about spine surgery is spine surgery tends to beget more spine surgery. And it's not uncommon for surgeons to have to go back in and take out the plate and do something different and then put back a plate. So the removal of these plates is relatively commonplace. The issue is that companies make different plates, and the companies want to sell you more plates over time. So the mechanism to unlock and remove a plate actually changes over time, and different companies are not compatible with each other. So all of this is to say, it's not infrequent for spine surgeons to be standing in the operating room looking at an X-ray and trying to figure out what the heck can I use to unlock and remove this plate. and then asking colleagues to come and take a look and give them suggestions. So the question was, could we solve that problem? Could we tell people ahead of time, what you need? So I'm just going to show you a couple of different examples of how widely different these plates could look. These are all anterior cervical plates, all made by different companies, all requiring unique, fancy removal tools. So it's you can't keep up with this. You can't memorize all the different iterations of this stuff over the years. So we took a bunch of X-rays from our institution, which does a lot of these. We built different models. This is a bag of words, bag of features model that took just a plain film X-ray and tried to delineate who made it and what kind of removal device do you need. Kevin Wong worked on this when he was a resident, and he's now a spine surgery attending at the Brigham, of all things. And this worked really well. And I think I have the data to show you, but this was the first described automated way of identifying the manufacturer and even the model of the hardware that's implanted, which then greatly facilitates its removal. And here's some of the results. So in the kind of the middle diagonal, you can see the concordance of what the model predicted versus the reality. And these are the different main manufacturers of the hardware. So with a reasonably high degree of certainty, you were able to tell who made what. So that's how we described it in the paper, I think. So 90% plus accuracy for getting your number one choice. And if you were flexible and you can take two choices, then that goes up, to 97%. All right, so switching gears a little bit, everything we've talked about so far has been imaging related, which in my specialty obviously is very imaging heavy, but the electronic medical record often consists of a lot of unstructured, non-imaging data, really, language written data. So we wanted to see if we can do some work in that arena. And these are just examples of structured versus unstructured data. And the vast majority, of course, is unstructured. It's just free form text that's very rich, but difficult to work with. So typically the way we deal with unstructured data in the EMR historically as clinicians is by creating an army of medical students and trainees who will sit down in front of an Excel sheet. They will read the chart, they will abstract from it the thing that you want them to, fill out an Excel sheet, which then becomes much more amenable. So they'll fill this whole thing out, and that becomes much more amenable to you analyzing it and coming up with interesting things to write up. And we were wondering if we could use some natural language processing, some NLP tools to help automate some of that, chart review. So one of the questions we asked is, can you tell me how many brain tumors this person has? So with Mets, brain metastases, cancer that came from elsewhere and went to the brain, it's not uncommon for a patient to have more than one brain tumor. And it's really important to know how many they have. That changes a lot about how they're treated and their prognosis and so on. And besides looking at the scan, which would tell you how many, that's the ground truth, the next best thing is reading the report. So if I wanted to ask a medical student to tell me how many brain tumors, these 1,000 patients had, I would ask them to read the report and just find the number in there and take it out. So we were wondering if we can design an NLP program to do that. And so we picked out a decent size, for us, a decent size training set, and labeled a portion of them manually, and then used kind of fairly standard NLP tools to try to figure out if we can answer that question. And this is the AUC showing that we had a really good predictive ability, that we could pretty consistently abstract this simple thing. We can abstract how many brain tumors each individual patient had. So this was more of a proof of principle. And the interesting thing is that if, as you sequentially label more and more reports, it's actually pretty quick that you hit the point of diminishing returns. So you only needed about 200 labeled reports to get you to a pretty high AUC. So the implication to me was that in order to end up with a useful NLP algorithm, the manual labor that goes into kind of setting that up is very reasonable. It's acceptable. 200 is a very manageable number. So hopefully this, opens the door to doing more and more of these similar projects. All right, so we have this is kind of is meant to be an overview of different aspects of the stuff that we're working on that we find interesting. I promised you I would circle back to this. So, the thing about IDH and predicting IDH really is only useful if you can tell that ahead of time. So we're really interested in seeing if we can incorporate, not yet clinically, but at least in a research backend, incorporate these algorithms in a way that we are prospectively looking at MRIs and then taking the patient to surgery, getting the ground truth from the surgery, and then going back and validating prospectively this model in an attempt to eventually bring it into the clinical sphere. And I think for it to be clinically useful, it would have to live on the PACS machine, and the people who are reading the scans would see this as a kind of an ancillary data point. So I'm really interested in that aspect of the work, because I don't want it to stop at a paper, but really get incorporated into a clinical workflow. So we're always, looking for projects, and we're starting new projects and finishing projects. And I'll tell you a little bit about our group, but we have a pretty robust group of people at different levels, medical students, residents. We've had pre-docs, we've had postdocs. So when people join the group, I tell them that at least for me, we should always be trying to look for clinically relevant questions to answer. It just so happens to be our forte, clinically relevant, because we're clinicians and that's what we do. We're sitting with these, I'm in clinic today. I saw patients this morning. We have a gap for this talk, and I'm going to see patients the rest of the day. So we're very much immersed in patient care. I think in general, machine learning is really good for pattern recognition. And a lot of what we do tends to be pattern recognition. So try to find a problem that has that, and that makes it tangible. Things that solve for repetitive tasks are useful for clinicians because it frees up time to do other tasks that are more cognitively demanding. The really tricky part is, of course, is always finding problems for which sufficient training data exists. That's particularly relevant for neurosurgery because, unlike diabetic retinopathy, for example, which has fantastic machine learning algorithms that have become famous, but brain tumors are rare, and it's really hard to compile a big enough training data set for you to have meaningful results out of it. And we have ways to try to mitigate that. And then ultimately, it's important, obviously, for people, especially for trainees, to have a publication and a first authorship and so on. And we help them with that. But I really also want to have some ability to interface with the model outside of the paper, because I think that really makes it much more tangible and useful to human beings. We also really believe in this idea of reproducible research. Sharing code, sharing data is really hard, of course, because of all the restrictions, but to the degree that it's possible, sharing data, I think would make us all better at what we do. And then I usually, when I talk to trainees, I show them this, not to nitpick on these poor people, but I show them this as an example of why it's worthwhile for us as clinicians to become at least proficient in this, because our many other has many publications all the time of people using these techniques. And this is a paper where people talked about, detecting surgical site infections in neurosurgery patients. And these are fortunately very rare events, but this was published as a really robust way of detecting infections. But if you actually look at the nitty-gritty of it, really not that hard, it's really just a very poor model. And I think it's important. You can only make intelligent commentary about this type of publication if you understand the underlying rationale. And I think it's worthwhile for us to be comfortable doing this so that we can use these models appropriately and dismiss other ones appropriately. The scary thing to me is that at the end of the conclusion of this paper was, this is a fantastic model and should be used in the clinical setting, whereas that's the opposite of reality. This audience knows better than anybody that, this whole thing has become kind of a big deal with a lot of interest and a lot of funding, and will continue to get bigger probably. And I just wanted to wrap up by talking a little bit about the way that we train our residents. Neurosurgery is a very long training program. It's the longest of all the primary medicine training. So it takes 7 years after medical school to get somebody to become a neurosurgeon, and almost everybody does at least a year, if not 2, of post-residency fellowship. And the way that we structured our program at the Brigham is the 4th and 5th year are research. So they have 2 years of dedicated time to spend on research. And research can mean different things to different people, but historically has meant bench, wet lab research, which a lot of people still do. But I'm proud to say that we've created ways for our residents to that are interested and inclined to spend their time on doing this kind of work instead. In other words, convincing a generation of people, that the older generation of people, for example, that this is as worthwhile to spend time and effort and energy on as it is, pipetting in the lab. That for the interested resident, this is something that is going to be useful for them across their career. And we think this is good because, like I said, it makes you better informed, not only in designing these, but understanding the metrics, understanding the biases, and it makes you a good collaborator with the people that are doing this on the back end, on the computer science side. The Congress of Neurosurgeons is one of 2 national bodies for neurosurgery, and we have a data science committee that I sit on. We have a scholarship in data science. So it makes me really happy that organized neurosurgery also recognizes the utility of this kind of work and encourages residents to participate in it. And I'll finish with this. What I tell the residents is that the reason it's worthwhile to become a clinician data scientist is because for now we have access to this data that other people have a hard time getting access to. And I would argue that we are the best suited people to design these algorithms that really serve the patient's best interest. The reality is that just about every other third party has other interests. It doesn't mean it's not a bad thing, but sometimes it's a good thing because it makes it more easy to disseminate. But we are clinicians. We are dedicated. We are oath bound to our patients. So our participation in designing these is not a bad thing. And we can also design them in a way that makes sense to maybe other clinicians, that maybe we can explain it to other people in a way that increases the adoption rate. And I think I'll stop there. And we've got a little bit of time for questions if there are any.
Hello, Omar. Thank you very much. That was a wonderful, wonderful tour de force. Folks, if have questions, please go ahead and type them in the chat and the Q&A boxes, and we'll have Dr. Arnaout address them. A couple of wonderful points. You had so many great points. The first, I'll start with the last point you made around the education, and that's something that I think we've done in radiology as well, and the feeling that we need to have clinically people with clinical acumen doing this work, and also understanding enough to assess the literature, as you showed there, a paper that was, hyped, and clearly, if you dig deeper into it, it's not a very good model, and maybe even not so clinically relevant, and so on. We've had a number of those kinds of papers being published just because people were excited about this new technology, and also being able to work as part of a team with data scientists to do that. So I think education is absolutely essential. And we have similar programs in radiology. So that's fantastic to hear. The other point that you made, which I love, is you're having models automate things that are tedious for you. So for example, a radiologist is very, very good at making diagnoses and interpretations, but we're horrible at quantifying things, doing quantitative metrics. So why not automate that? So I loved those points. Very, very important. We do have a question here. Let's see. Thank you for your excellent talk. I'm wondering, what's your thought on machine learning in the arena of vascular neurosurgery? What are the challenges of AI in vascular neurosurgery, in your opinion?
Yeah, so vascular, I didn't really talk about vascular so much because it's not my clinical area, and I don't think I can mention maybe company names, but there is a pretty well-known company now that does vascular only, specific vascular AI in neurosurgery, and it was started by a neurosurgeon and it's taken off. AI has actually been implemented quite a bit in vascular neurosurgery. Now they have these fantastic algorithms that can detect intracranial hemorrhage, that can detect ischemic stroke and quantify ischemic stroke. And in some places where it's been implemented, actually are being used to triage patients that would go to different centers based on the types of strokes that they're having. And it's being used to facilitate the time from hitting the door to getting to the angio suite, which can be life-changing for certain types of strokes. They've taken that now and they're adding another layer of detecting, kind of like what I described, outside of the setting of an acute stroke, but detecting aneurysms and AVMs and other lesions that then would require an intervention. So I think the challenges in vascular neurosurgery are the same as they are in other parts of neurosurgery. It's the small size data sets. I think that are the difficulties we have with sharing data with each other because of the privileges. I think those are the challenges. On the other hand, there are some areas where it's really amenable because CT scan and MRI is universal for people who have strokes, for example, and anybody with an aneurysm or AVM often gets many data points, many images over their lifetime. So you can accumulate a decent amount of data. But I think it's overall similar, pros and cons, challenges, as the rest of neurosurgery, but it has taken off quite a bit in vascular for sure.
Yeah, we've kind of gone after sort of the low-hanging fruit in the beginning of radiology, and you mentioned this as well, that the pre-processing of the data and the labeling of the data can be very, very tedious, and we have difficulty getting access to heterogeneous data sets so that we don't inject bias into the data set. But the segmentation problem you were able to do with, I think, a couple hundred nicely segmented, which is a doable prospect. One question I had, you did a model where you used transfer learning, where you used a model that was done not on medical images. Was that the segmentation piece? Remind me if that was that particular case.
That was the meningioma segmentation piece, yeah.
Yeah. But right now we're dealing with, can we get enough heterogeneous data into our data sets to be able to train our models so that they can generalize to other patient populations? And I imagine this is difficult to do with some of the rare cases that you're dealing with in neurosurgery. And gosh, you went through a lot of things. You're looking at GANs and creating new tumors, and that would be a way to help if you don't have access to data. And the NLP. One of the things I think, again, we started with pixel data in imaging predominantly, But bringing in the robust information that is in the electronic medical record is another wonderful piece to take a look at, and perhaps even to find things that maybe we weren't putting as much value on as an important feature. We have another question here. Let's see. Thank you for your outstanding talk. My name is Ahmad, and I'm a post-medical school research fellow in neuro-oncology at Miami Cancer Institute. What are your thoughts on how to ensure medical students and residents retain their proficiency in AI, ML, and CNN and related tools after learning intensively in dedicated research years, but then going back to clinical experience? So it sounds like they've done their research experience like you get to do in neurosurgery. And then let's say, how do we ensure that you retain proficiency in a field that is rapidly evolving? With the intensity of neurosurgical training may not be conducive. So maybe he's kind of asking you, how the heck did you do this? Going through, 7 years of training in neurosurgery, how did you manage to learn this and get involved in this area?
Yeah, it's a good question, and it's not unique to AI or machine learning. It's the same if that person had gone to a wet lab and did wet lab or got a PhD and then came back. It's really hard, right, to keep up with this kind of disparate skill set and this fund of knowledge that if you don't keep up with, very quickly becomes outdated. And I think really the answer to that is collaboration. Because I'll tell you my personal experience. When I was a fellow and I had quite a bit more time, when I started the Brigham, I spent a lot of time myself, setting up the infrastructure and putting all these data sets together. I did a lot of the labeling myself, even some of the model building, I programmed myself, and I really enjoyed doing it. I thought it was fun to do. I never did it to the same level that, an actual professional, PhD person would do, but I could do it relatively, proficiently, like relatively well. But since I became an attending, and every year since, I've had less and less and less time, and our patients are very sick. And, I run the ICU and I run the floor, and I do 300 brain tumor surgeries every year. So I haven't programmed in a long time, as much as I would love to. But you have to collaborate, and you have collaborators who are phenomenal at what they do, and they keep up and they know. Just like, honestly, just like in medicine, the apex of my skill set is in the operating room doing this very difficult thing of take out brain tumors. But when I have a patient in the intensive care unit, I defer to the intensive care unit doctor who's sitting there reading the papers every day and knows much more than I do about the nitty-gritty. So it's the same in medicine as non-medicine. You have to have good collaborators, that everybody can do the thing that they're particularly good at. But you also have to have a shared language and a shared infrastructure so that you can also be a good collaborator. So I think that's the key, is that during those years you acquire those. That's never going to go away. And then you keep up by collaborating with people that are keeping up, full time.
Well, I think that's a wonderful message. And again, sort of team sport, and being able to at least communicate, know a little bit about both fields, and being able to communicate across that bridge. And that just is another reason why education for medical students and residents and fellows in this area is very, very important. We have a question from Charles Jennings. What do you see as the potential for new imaging methods, e.g. advanced diffusion MR, functional connectomics, etc., to predict brain tumor outcomes, and what will be the challenges in developing algorithms that take advantage of these methods?
Yeah, so it's a good question. I don't know if you like my answer or not, but I think that there's two parts I'll tackle. I tackle the clinical part and then the algorithm part. So, we're at the Brigham. We have access to a lot of really advanced MRI techniques, and we leverage that. For example, we do a lot of spectroscopy that's just doesn't exist elsewhere. The problem with connectomics in particular is that so far it's been really disappointing, and maybe this is a controversial thing to say, but it hasn't really made a difference clinically at all. People have built whole things about it, but it just hasn't moved the needle that much. there's no question that as new modalities come online, things will make more and more of a difference. And I think automating some of the connectomics, maybe that's part of it. So I think there's no question in the future additional imaging will help. So far, I haven't seen something that has really moved the needle that much. I think the challenges are, one, really tiny data sets, even tinier than kind of standard MRIs. And then two, is that even if you can use advanced MR techniques and you can come up with something really, really interesting that's predictive about the patient's progress or nature of their disease, it's actually really hard to generalize, even harder to generalize than usual, because nobody else has access, or very few people have access. So actually, for that reason, the projects that we've done so far, we've specifically tried to only use structural MRIs and nothing else, because it's universal. Everybody has those, and then maybe our algorithms will be a lot more generalizable. So I don't know if that's a satisfying answer, but I think it's a fascinating field. But anyway, my 2 cents.
Fantastic. We have another question here. What is the mechanism for a treating clinician to ask a neurosurgeon for advice about a potential case? Chart review, interpret imaging, offer advice, options, surveillance. Is this time billable? Well, this gets at an interesting thing. So just one comment on this question, and that is most of the machine learning models that are FDA approved currently, there's a huge percentage, 75, 80%, that are in imaging, but we still don't know who's going to pay for these things. But what are your thoughts around that kind of thing?
Well, so this is obviously it's a clinical question. So there's a formal process. For example, within the institution, Epic has ways of getting an informal opinion, a formal opinion, a referral into the clinic. Outside of the system, there are ways of getting into the system. But really, what I found personally and from the people that I talk to is most of us are very happy to discuss a case, whether it's formally or informally. So if you email me, I'm happy to discuss a case with you. The thing about surgeons is that generally, we don't tend to bill for this kind of thing. In medicine in general, any interaction that has to do with patient care is technically a billable event. If you're rendering an opinion that's based on your expertise, that's a billable event. But surgeons are surgeons. We really, we get reimbursed to do surgery. So most of us, myself included, are more than happy to discuss cases offline. And it's generally not a billable event.
But yeah, no, I think, one of the things that we've seen explode in radiology is using machine learning AI models to interpret imaging, which is something that trained physicians, radiologists do extremely well. But what one of the projects that you mentioned that I really like is automating quantitation and volumetric measurements, which are tedious, time consuming, and I think there would be a way to justify sort of a return on investment of using that. The last point I wanted to make is trying to get these things to you at the point of care where you can use them. And I think that's the next piece. That's something that we're working on very heavily at the data science office in trying to help researchers and industry partners to actually test things in the clinical environment and get them into the clinical tools that you're actually using, such as the PACS or for perhaps the electronic medical record or something in the OR and so on. So those are where we're really going to see these kinds of things make a huge impact.
Yeah. And we didn't really talk about that, but that's a really good point, Kathy. I think that these things are really only useful if they're available at the point of care. I think ultimately that's the goal. And the point of care for us, for you guys, obviously that's the PACS machine, but for us, it's also the PACS machine, but it's also the imaging in the OR. And I didn't really talk about intraoperative use of imaging, but we heavily, there's no case that I do that we don't use navigation for, and we use imaging. And being able to incorporate some of these algorithms into the navigation and into intraoperative imaging, intraoperative ultrasound, intraoperative MRI, I think that's going to be paradigm changing, and it's something that we're very interested in exploring. So I think that's a very good point.
Fantastic. Well, we're going to have you back and check in and see how you're doing and what you're working on next. I want to thank you so much, Omar, for a wonderful lecture. And I want to wish everyone a happy holiday season going forward. And we'll see everyone in the new year in January for our next AI4C conference. Thank you so much.
Thank you, Kathy. Happy holidays, everyone. Take care.